I'm Anne Statchowicz. I'm a urogynecologist at Christ Hospital. And Marcia and Chris were so gracious to invite me to just give a talk on women's health, my area of women's health, which is called urogynecology. Just get the word out, because I think a lot of women don't even know that my little niche of medicine exists, and I think we have a lot to offer women in particular. Well, that's all I care for. I don't see men, so yeah. Okay, you can go ahead and click. Routine, I don't have any disclosures. I'm not getting any special perks from giving this talk. Just want to spread the word. Okay, so what do I do? My physician title or my specialty title, the formal name is female pelvic medicine and reconstructive surgery, which is a really silly acronym. They've shortened it now to urogynecology and reconstructive surgery, but all that really means, if you can click, is that, I am a subspecialist under the overarching OBGYN specialty of medicine. There's also some folks who do urogynecology, but they went through a urology training. So there's two ways to get to where I am. But in the world of medicine, it's a really new specialty. Like urology or obstetrics and gynecology have been around since kind of the dawn of modern medicine, and urogynecology, which were kind of a little bit of both specialties mashed into one, was only formally recognized as like a board certified specialty in 2013. But we, as a specialty, focus on the pelvic floor in this area of women's health, which I think in a minute, the next slide talks about a lot of the subcategories of problems women might have related to the pelvic floor. But I kind of take a little bit of gynecology and a little bit of urology and do that. And then there's other things like women's preventative health or obstetrics delivering babies that I don't do. And then in the world of urology, I don't take care of anything from kind of the bladder up. So anything like kidney stones or kidney cancer, anything like that, it's kind of out of our realm too. So we're really kind of a little niche right down here. Okay, so the pelvic floor, what is the pelvic floor? I like patients to think of it as kind of the bottom of a Pringles can. So if your core is the sides of the can, your diaphragm, which helps you breathe, that's the big muscle up here, is the lid of the can. The pelvic floor is the base of the can. And it comprises bony structures, ligaments, tendons, muscles, and it helps our pelvic organs function the way they need to. Your bladder, your rectum, your vagina, and uterus. So think of, this is the bony pelvis, and if you kind of turn it on its side, you could, in theory, kind of pass your arm right through it. There's nothing really bony that's holding everything up above it. You can click. So I kind of flip that on its end. I'm just trying to give you a step-by-step visualization. And then within that bony structure, there's this big bowl of muscles. And that's what's kind of filling the pelvis now in this picture. And the bony, or the muscular bowl that's filling your bony pelvis then has three openings. So one for the rectum, the vagina, and then for the urethra. And the pelvic floor should sort of have this constant state of lifting, because we want it to hold all our things above it up and in. And it really should only relax in a few scenarios: when you need to evacuate your bladder or your bowels, or when you're having a baby. So those are the three scenarios we need our pelvic floor to relax and kind of descend. And then we can also engage our pelvic floors actively when we need to, like if you're trying to do a Kegel, if anybody's heard of squeezing their pelvic floor. Or we do it kind of subconsciously when you sneeze. You actually have a reflex that lifts your pelvic floor. Or even when you're exercising or having intercourse, those things all result in engagement or lifting of the pelvic floor. And then this is just another picture of that kind of muscular bowl here, filling with the openings that we talked about, and then the organs kind of inserted. So what are the problems that can arise from a faulty pelvic floor, or if there's an issue going on? Stress incontinence is one of the most common things I take care of. So cough, sneeze, laugh, jump, anything physical that puts pressure on the pelvic floor can result in leakage of urine. So that's called stress incontinence. Pelvic organ prolapse is where the bladder or the uterus or the vagina, or occasionally sometimes the rectum too, can prolapse down and out. And so you can have like a bulge kind of coming out of one of those three areas. Overactive bladder is also very common. This is a problem where someone might complain of urgency to get to the bathroom for the bladder. Like they get the sense they need to go to the bathroom, but it's almost too late. Like you're running to the bathroom. There's also frequency, like they feel like they're constantly in the bathroom. And sometimes women say they just can't get to the bathroom in time. That's a really common symptom of an overactive bladder. Bowel leakage. So whether that's leakage of gas, like accidentally passing gas, or accidentally passing a little bit or sometimes a lot of it of stool. Those are things that can happen. We also take care of recurrent bladder infections. That has a lot to do with our kind of urogenital health. Before and after menopause is a big time when women often become symptomatic with recurrent UTIs. Some women have something called bladder pain syndrome. Another formal name for it is called interstitial cystitis. You might have heard of IC, people talking about that. But essentially that is just a symptom complex of pain when their bladder is full, having to go to the bathroom frequently to alleviate that pain. And so there's a whole kind of treatment algorithm to try to help manage those type symptoms. So in trying to fix some of these problems, in the past, and still currently today, there are a few scenarios where we'll use like a permanent implant in the body, and the general term for that is called mesh. And so urogynecologists are specially equipped to operate on women who have complications from vaginal mesh or different types of complications from really not just mesh, but any type of pelvic surgery that's gone awry, like a hysterectomy that had a complication. We can take care of that. You can get cysts, just like you've probably heard of ovarian cysts, or cysts in your breasts. There are different types of cysts that can occur in the vagina or around the bladder called urethral cysts. And I kind of already covered that. So this is like just the 10,000-foot view of urogynecology as a specialty. But I figured we would pick one little topic today to go a little bit deeper on. And then if you have questions, though, any question is fair game about other pelvic floor disorders that I've kind of touched on. So what is pelvic organ prolapse? This is where the pelvic organs, mainly the ones that I would take care of would be like a prolapsed uterus or prolapsed bladder or prolapsed urethra. I know I said prolapsed rectum, which is actually a little bit of a different problem that's managed by a colorectal surgeon. But we work together all the time for patients that have kind of multiple problems that both of us can fix. So when you lose support to the normal structures that are there of your pelvic floor, main risk factors are going to be sometimes women have a little genetic predisposition to having issues with their pelvic floor. It runs in families. Some women have pregnancies and then childbirth, and that is often a main risk factor for having problems with your pelvic floor, not just to develop prolapse, but any of those prior issues that we talked about. And there's a bunch of other risk factors as well, like going through menopause can contribute to some of these issues, but when you lose support of your pelvic floor, you can develop a prolapse. And usually the symptoms patients describe are going to be not so much pain, but they feel like a heaviness in the vagina, like something's just weighing down that area. Or they might see or feel discrete kind of roundness or bulge coming out of the vagina. And these are, sorry, a little graphic for those of you who haven't seen it, but these are some pictures of prolapse, okay? So this is a picture of cervical or uterine prolapse, where this is actually the opening to the uterus that you can see from the opening, or you can have a prolapse of the front wall or the back wall of the vagina. But in the end, it's just more nagging. It's an uncomfortable feeling. And it's really not a life-threatening situation or an emergency, although it can feel very alarming the first time somebody realizes this is happening. But it's generally just a really annoying situation. Okay, we talked a little bit about risk factors, but here are a little bit more. So genetics, pregnancy, childbirth we talked about, lifestyle, smoking can cause microscopic damage to the tissues, the blood supply, the nerves that can support the pelvic floor. Other lifestyle things like patient who works at the Amazon factory, who's lifting really heavy boxes all day, every day. That can put a lot of strain on the pelvic floor and result in some pelvic floor damage. Pelvic floor injury, so if somebody has had a really hard fall or a car accident or any type of acute type of scenario that would injure the pelvic floor. And then other health conditions, so like a chronic cough, anything that's putting chronic constant pressure on the pelvic floor can result in a pelvic organ prolapse. We can see, can I click on this? Can you right click on it and just this is just like a pictorial showing like how the pelvic organs can descend in different ways, but I think it'll be okay. Okay, so if this is you and this is a problem you're dealing with, what can you do? Well, there's a whole myriad of options, and if you come to see a urogynecologist, or even if you start out and you go just to your OBGYN and ask them what's going on, you should be presented with a wide gamut of options that range from very conservative things to a little bit more aggressive treatments like a surgery or something like that. I'm not sure what comes next. So conservative treatments. Since this is not a life-threatening issue, it's more about someone's quality of life. And there are many women that have a prolapse. They might be aware of it, but it doesn't really bother them. Then that is someone who totally can just observe, and we just can kind of keep an eye on it over the years. You can go to see a pelvic floor physical therapist, which is a very specialized physical therapist who only treats women in this area. They may treat men. There are male pelvic floor disorders as well, but they're really all women. I've actually never met a male pelvic floor physical therapist. But so it's kind of an intimate one-on-one experience. You're kind of off in a little room like this. And they're a wealth of knowledge. So much knowledge just about women's bodies that they can impart on patients that know. Then there's active managements. A pessary is something I think I have a slide on coming up. It's a non-surgical treatment that is placed in the vagina. It's basically like a silicone insert, if you've ever heard of a diaphragm, or a NuvaRing is a form of birth control, but it's like a little flexible ring that goes in the vagina. So this is kind of a similar concept, but it's something that you place in the vagina and it just expands and it holds everything up so nothing can fall down and out. And then there's surgery. So, oh, I said. So to talk a little bit more about physical therapy, it's probably most effective for milder stages of prolapse. So the woman that comes with kind of mild symptoms and mild findings on exam, they have every reason to think that they're going to have a lot of improvement with physical therapy alone. But somebody who comes with a really advanced prolapse might not have as much benefit as you would kind of say. And very reliable at improving symptoms of prolapse. And it also may improve kind of how advanced, like how far something is hanging out of the body. We stage it 0 to 4, and it might improve it by 1 stage. So it might not take away the actual physical bulge, but it helps alleviate symptoms significantly. So here's the pessary. So they come in all different shapes and sizes, but these are all made of silicone and they're flexible. So they can start out being like this little, and actually there are ones that are about this big, which is wild to think about. But it's a very individualized approach where if somebody is interested in a pessary, they come in and we do a little trial and error to figure out which one fits their body the best and which is most comfortable for them. And if a pessary is kind of fit correctly and it feels right, then it's almost like wearing a comfortable pair of shoes where you put them on and in the first few minutes you're like, yeah, I'm wearing shoes. And then you go about your day and you kind of forget that you're wearing shoes. And then until it's time to take those shoes off or take out your pessary. Surgery, there's multiple options. It takes a kind of a long discussion in the office to talk about the options and how we want to approach it, very individualized, patient-to-patient basis. They're mostly outpatient, where you go home the same day. And I usually tell patients recovery is about 2 to 4 weeks where you're trying to get back to feeling like yourself. But I put you on really kind of conservative restrictions as far as activity for about 6 weeks. Okay, so if you have a problem, like one of those things we talked about in the beginning, how can you find a urogynecologist? There's about, I think, 10 of us in the city, so it's not that common. And 10 is actually a lot for a city of like the size of Cincinnati. Like Indianapolis or Columbus has far fewer, maybe 5 in the whole city. So we are fortunate here in Cincinnati that women have this widely available to them. But you could ask your primary care provider. I get lots of referrals from just internal medicine doctors or family medicine doctors. A regular OBGYN would be easily able to refer you. Or you can just call up a urogynecology office. And the front desk person might ask you, like, why are you coming in a general sense? And if they think it's not quite a good fit, they may say, you might want to check with your OBGYN first to see if that's something that you really should come to us for. But if it sounds like it's pretty clear, like you have bladder leakage, then they'll set you right up. So you don't necessarily need a formal referral to see a urogynecologist. Okay, so that was really it. So I'll take the bag. I don't know did anyone write down any questions? I think I can also just come up with other common questions people ask me. Yeah, I think there's a couple of questions in here that I kind of wrote. So let's talk a little bit about just some bladder leakage questions. That is an extremely common issue. I would say it's certainly an issue that becomes more prevalent as women age, and the type of leakage depends on the patient's age at the time that they present. So most women who are in their 20s, 30s, 40s, 50s, if they come in and they say they have bladder leakage, many of them are going to be just talking about stress incontinence, the cough, sneeze, laugh. I can't jump on the trampoline with my kids anymore, that type of leakage. And then as women get a few years older, typically, sometimes it's starts earlier, like in their 30s or 40s, but 50s, 60s, 70s, 80s, more of those patients are going to start complaining about urgency. Can't make it to the bathroom in time. I pull in my driveway and I turn my car off and I go to reach for my doorknob on the front door, and I'm already kind of having an accident. I can't get there in time. So these issues are extremely common. I would say, 50, 60, 70% of women are going to be having some sort of these symptoms at some point in their life. And a lot of the treatments that we talked about for pelvic organ prolapse also apply for that. So physical therapy, there are medicines to help bladder leakage. There are surgeries to help bladder leakage. There are things like Botox, which we use for the face, that we can use for bladder leakage in the pelvis. So lots of options for that too. I get a lot of questions about that.
Question.
Yeah.
Is there anything proactive that people should be doing
Yeah, I mean,
before they're having those kind of problems?
I think that the pelvic floor, the muscles, just like we exercise the rest of our bodies, I think the pelvic floor musculature is often neglected. So by the time somebody is in their, later decades of life, that those muscles are so weak that yes, they can go to physical therapy and start strengthening those muscles, but in some cases it's just kind of too late. So I think the younger you start kind of actively using your pelvic floor on a regular basis, doing Kegels, going to a physical therapist just to learn about this part of the body, I think could benefit you immensely in a proactive sense. Absolutely. If you asked your general OB/GYN for a referral with pelvic floor, I don't really think you need like a very specific diagnosis to be able to go and see them. And insurance does cover most visits with pelvic floor physical therapists. There are occasionally like a private pelvic floor physical therapy practice that doesn't accept insurance and they're self-pay. But most like hospital-associated pelvic floor physical therapy groups or like the larger physical therapy groups, I'm not sure if Mobility Fit has a pelvic floor physical therapist. They might. But like Oxford Physical Therapy or heard of like Novacare Rehab are big physical therapy groups in town that offer pelvic floor physical therapy. So they're becoming more and more prevalent as well, which is awesome. And Cincinnati, I think, has a very good population of pelvic floor physical therapists. Other cities aren't so well off, like Dayton. I think there's kind of a lack of pelvic floor physical therapists, like 20, 30 minutes north of us. Columbus, I think, is hopefully up and coming. So Cincinnati's doing pretty good, I would say, in the women's health realm. Yeah, good question. Anybody else?
I have a question. I'm just curious about it's called the pessary.
Mm-hmm.
You mentioned that so they are put in and then there's a certain time where they are supposed to come out. Is there a certain time frame, or how long does that usually stay in?
So if patient has good manual dexterity, they can learn to take it in and out themselves and just use it as they wish. So I usually, if a patient's doing that, I tell them to take it out maybe one night a week and leave it out and just give everything a chance to kind of rest, and then they can use it again. Some people take it out every day, but then I also have patients who have no dexterity and can't take it in and out, and then they may have it in for 3 to 6 months. And they have to come back in the office and we check on things. The biggest thing with the pessary is it just can't be neglected. Like if a patient develops dementia and their family doesn't know that they have this in, that can be a big problem if it's left in. I've had patients come back with the pessary in for a decade or 2 decades, and it's always a little bit nerve-wracking, like what are we going to find? Or you have some issues. So you can kind of make it, somebody can make it what they want it to be in terms of how frequently it's taken. I think Europe they'll let people keep them in for like a year, and they come in for a yearly checkup. I think that's a little bit too long to leave it in, but it's working for the Europeans, so. Any other questions? Cool. I mean, spread the word. I think as women, we deserve better health care. And so I think the more we talk about these things, more and more women are going to get more comfortable talking about what's happening to their bodies, and our ability to provide care. Like the number of urogynecologists will increase with time. The number of pelvic floor physical therapists will increase with time. So get out there and talk to your friends about it. It's really important. And a lot of people don't want to talk about these types of things because it can be kind of embarrassing. So I'm glad you guys came and maybe learned something you didn't know about before.
I love social media, like when people are, the people that are on there like, talking about
Yeah.
things, and it's really nice.
Yeah, I think that's a really positive aspect of social media, for sure. Like I think the generations and like prior generations didn't talk about these things at all. And the thing about pelvic floor disorders is that they can be really isolating. Like as patients get older, they just will kind of become reclusive and not want to go out because of their issues, and that's really unfortunate. So, yeah, thank you guys.